The environment in the NICU creates a stressful situation for the parents where they search for help. One of the main reasons for parents to experience anxiety was related to lack of information on infant's condition. Giving them a glance of hope could give them emotional strength. I am Josefina Andrea Ombao, Master of Arts in Nursing student, major in maternal and child. I am going to discuss about the lived experience of parents in the care of infants in the neonatal intensive care unit. The objectives of the discussion is to determine the lived experiences of the parents in caring of infants in the NICU. What is the parental support received in dealing with caring of infants in NICU? What are the coping strategies used by the parents during infant hospitalization? What are the causes that influence or contribute to the stress levels of the parents? And what are the effects on the infants involved in parent participation? Why is this study important? Parents are anxious about their baby's clinical condition and survival. They have lots of questions playing inside their mind that sometimes burst into anger to cover up their worries and fear. This study will give a closer look to parents' point of view on their child's NICU stay, how they cope up with the situation, and the support they get coming from the healthcare team. This could be used as a guide for NICU pediatric healthcare team on how they will approach the parents during difficult situations and anticipate their needs as a family. In this way, as nurses, we can deliver better nursing care not only to the infant, but to the parents as well. This will help them prepare for the baby's discharge and build up confidence in taking care of their child. The study is not without limitations. First, the small sample size limited the detection of differences between the two groups. This was derived from a selected population of preterm newborns with surgical diseases and their parents. Moreover, the NICU receives infants from the region of Campania in Italy, some of which are located far from the hospital city proper in Naples. And these patients were excluded because of the increased level of stress of being far from home. In addition to that, the socioeconomic status was not evaluated. Lastly, it was not determined which procedure contributes to the stress level of the parents and newborn, as the information regarding the lived experiences of the parents are limited and needs further studies to identify their specific needs. The literature used in this study was taken from the Italian Journal of Pediatrics entitled Supporting Parents in Taking Care of Their Infants Admitted to a Neonatal Intensive Care Unit, a prospective cohort pilot study that was published last April of 2017. Prematurity and various infant illnesses are the multifactorial causes of NICU admission. Parents are more likely not aware and well informed about the standard of treatment and process of admission for their newborn that places them into the risk for stress and anxiety. The ability to execute parental roles are now put into test due to physical, emotional, and mental separation from the baby. Parents are seeking for answers about the situation and progress of their infant. The information they will receive influence their coping mechanism to handle stress. Support from the healthcare providers have huge impact on their coping abilities in order for them to participate in the care of their infants. It was recognized that parental presence at the bedside in the NICU reduces stress to the parents and has a positive effect to the infant, and open communication between parents and healthcare providers assures the parents and helps decrease anxiety. Multifac- Multifactorial aggravates parents' reaction to their infant admitted in the NICU that may have affect their behavior in fulfilling their role as parents. Understanding what the parents have been through during their infant's hospital stay can help us meet their needs. Casey's model of nursing was developed in 1988 by Ann Casey while working in pediatric oncology. It is focused in working in partnership with children and family. It composed of five concepts, including the child, the family, the health, environment, and the nurse. The aim of this theory is that the family or parents, together with the health care staff, are the best caregiver for the child or infant. Unrestricted parental presence in the NICU, parental involvement in infant caregiving, open communication with the parents reduces stress and encourages participation of the parents. Some of the few measures are assurance of the staff to communicate with the parents where there is a chance of condition or change of condition from the infant can help relieve stress when unable to be present at the bedside. Providing a supportive environment helps prevent to cope up with stress. Orientation to the NICU to parents with premature infants is effective in reducing stress and develop visiting pattern that promotes attachment that with the infant while assuring adequate rest and sleeping patterns for the parents. We focus on the infant as the primary recipient of care for their well-being. As a healthcare provider, we sometimes focus on the illness and not the underlying causes and available resources for the infant. Healing doesn't come from medicine and procedure itself, but rather from the love and care coming from their caregivers, which are the parents and the nurses responsible with the infant. As they work side by side, they create a harmonious environment which is conducive to the healing of the infant. The combination of the five concepts developed by Casey helps the nurse to understand what the parents experience and can decide a strategy to decrease stress and encourage participation of care. Being attentive to the monitor, machines, and infusion pump alarms, lowering down the voice of the staff, and setting a schedule, dimming light to keep a calm NICU environment may help in the mood and relaxation of both parents and the infant. Describing life experiences and gaining insights in this study uses a qualitative research design. It answers why and how a certain phenomenon may occur rather than how often, and approaches are employed across many academic disciplines, focusing particularly on human elements on the social and natural sciences. Each parent has their own unique experiences, their concerns regarding their infant's hospitalization explains the existence of stress. There are no clear, definite steps to follow in collecting their lived experiences because every parent's reality is different from others and coping strategies depend in every situation. In this study, parental presence during NICU length of stay and participation of parents were demonstrated to associate with the satisfaction and stress level of the parents. It can be a guideline on how to develop coping strategies for the parents during infants' hospitalization. A total of 60 parents and 30 newborns in the family-centered care group and 66 parents and 33 newborns in the non-family centered care group. were approached for recruitment. However, during hospitalization, 11 parents declined and 4 newborns died as reported. In the final analysis, 96 parents were included with their newborns. The family center care group was composed of 24 mothers and fathers with their children, and the remaining 24 mothers and fathers, together with their children, composed the non-family centered care group. The inclusion criteria for parents consists of the age of more than 18 years, no single parent families, no manifestation of psychiatric pathologies, no drug addiction, and the parents who live in Naples are selected. Experimental research and non-probability sampling were used in collecting and analyzing data. Lived experiences of the parents with infants admitted in NICU are collected to identify stress and coping mechanisms. Parental stressor scale in NICU was developed by Miles and Funk, which is used to measure parents' perception of stress in NICU. The scale consists of four subtests that measure stress related to sights and sounds, appearance and behavior of the infant, the impact of the parents' role and their relationship with their baby, and the parents' relationship and communication with the staff. Their responses were scored on a 5-point Likert scale ranging from 1 for not at all stressful until 5 for extreme or severe stress. Questionnaires were introduced during the parents' visit to the NICU without interruption of their infant bonding or staff interaction. Parents with critically ill infants were left undisturbed to avoid emotional strain during critical situation of the infant. The non-family centered care group were enrolled from March 2014 to September 2014. During this period, parents were permitted to visit their baby for 1 hour a day. On the other hand, the family center care group was enrolled from October 2014 to April 2015, and parents had access to their infants for up to 8 hours a day during that time. During visiting hours, pediatric nurses taught parents the corrective procedures and practices in the NICU, in the interview room, or in the ward. Both parents could access the NICU, but they had to wash their hands and non-gowns in the filter zone before entering to reduce the risk of contamination. Initially, they could only observe their infants and routine procedures such as venipuncture, heel stick, and mechanical ventilation when it was possible and if the parents felt ready. They participated with pediatric nurses in the care of their infants by bathing, changing diapers, breastfeeding, and holding them during painful procedures. Parents could observe the clinical bedside rounds and hold meetings with physicians in the interview room. The doctor explains to the parents the newborn's clinical situation and tries to establish a therapeutic alliance with them. On the day of the infant's discharge, the parents in both groups complete two questionnaires regarding their satisfaction and stress level with respect to their experience in the NICU.